So good morning, everybody. My name is Emmanuel Futier. I am professor of anesthesia and intensive care in Clermont-Ferrand University Hospital in France. And I would like to share this few moment and this occasion to address my most sincerely thanks to the scientific committee for the invitation to discuss about neuromuscular blocking agents in COVID-19 patients. Here are my conflicts of interest, and as you can see, I think that nothing will influence my message. The first point, and as an introduction, I would like to discuss is that it's probably important to underline that patients with COVID-19 do not all require invasive mechanical ventilation, and this is obviously also the case for patients with severe COVID-19. And I'm quite convinced that most of you have already seen that some patients requiring respiratory support may be successfully treated using NIV and/or high-flow nasal cannula. And as an example, in the recently published REMAP COVID trial in JAMA this week, it's interesting to consider that almost 40% of patients receiving hydrocortisone did not require intubation and invasive mechanical ventilation at any time. So obviously, as a consequence, and at least for these COVID-19 patients, the question of whether neuromuscular blocking agent should be used or not, obviously does not apply. The other point I would like to focus on relates on the clinical characteristics of COVID-19 patients with ARDS. And there is accumulating evidence suggesting that, in fact, physiological differences between ARDS from COVID-19 and other causes appear small, with lung morphology and respiratory mechanics being very similar to that of more classical ARDS. And this was also found in this other study, in which, similarly to ARDS from other causes, the author found that respiratory mechanics of COVID-19 patients is heterogeneous. Obviously, recruitability is heterogeneous, but average recruitability is very similar to ARDS from non-COVID etiology. And as a consequence, and at least in my view, but we can obviously discuss it later, it's therefore logical to consider that ventilator strategies that were found beneficial to minimize lung stress and ventilator lung injury should also apply in patients with COVID-19 requiring mechanical ventilation. So what are current recommendations in patients with COVID-19 related ARDS regarding muscle relaxation? As you all know, the Surviving Sepsis Campaign guidelines for COVID-19, published in March this year, issued a weak recommendation to use neuromuscular blocking agent to facilitate protective lung ventilation in COVID-19 patients with moderate to severe ARDS. And to that end, the recommendation is consistent with that of several professional societies guidelines, including the Surviving Sepsis International Guidelines for Management of Sepsis and Septic Shock, published in 2016. The recommendation is also consistent with the Clinical Practice Guidelines for Sustained Neuromuscular Blockade in the Adult Critically Ill Patients, and in which there is a suggestion with a weak recommendation to consider the administration of continuous IV infusion early in the course of ARDS patients, at least for those with a PF ratio lower than 150 millimeter of mercury. These recommendations were mostly based, obviously, on this meta-analysis, including the pooled estimates from 3 randomized controlled trials, a total of 431 patients, so a quite small number of patients, showing a reduction in 28-day mortality and ICU mortality with an neuromuscular blocking agent infusion as compared with no neuromuscular blocking agent infusion. The results of this meta-analysis were largely supported by findings from the Accurasis French multicentre double-blind trial, in which the use of continuous infusion of cisatracurium for 48 hours in patients with severe ARDS was associated with a reduction in 90-day mortality and also more ventilator-free days in patients allocated to the neuromuscular blocking agent group as compared to those receiving the placebo. So what is also current practice regarding the use of a neuromuscular blocking agent in patients with ARDS? And probably the first information supported by findings from the LungSafe International Observational Study is that, in fact, neuromuscular blocking agents are used sparingly in patients with ARDS. And as you can see, in this study, overall, 20% of patients received neuromuscular blocking agent, and even in those with the most severe form of injury, neuromuscular blocking agents were administered for a total of 40% of patients. The situation seems to be quite different or somewhat different in COVID-19 patients for whom neuromuscular blocking agents appear to be more largely used, and the results from the COVID-19 Spanish ICU network study found that adjunctive therapies are commonly applied, in fact, in COVID-19 patients, at least those requiring invasive mechanical ventilation. And as you can see, in these 742 patients, neuromuscular blocking agents were used in 72% of them and up to 80% of them in case of severe ARDS. Regarding neuromuscular blocking agent utilization in ARDS, it is also important to underline that the results of the ARDS trials was subsequently challenged by the publication in 2019 of the results of the ROSE trial by the PETAL group. And in this study, the use of neuromuscular blocking agent for 48 hours, did not influence patient outcome without statistically significant difference in 90-day mortality. However, it's also important to consider that apart from stopping the trial for futility without stopping rule, which in fact renders the ROSE and quite underpowered study, it should be noted that the use of rescue therapies in these trials, and in particular prone position, was not standardized. And as you all know, the use of prone positioning is strongly recommended in patients with severe ARDS. And this recommendation is obviously heavily supported by the finding from the PROSEVA trial, in which prone position applied early during the course of patients with severe ARDS was associated with the huge difference in mortality. And interestingly, it also should be noted that in the PROSEVA trial, neuromuscular blocking agents were used in almost all patients, since 82% and 91% of patients in the two groups received neuromuscular blocking agent for a duration of almost 5 days. And finally, the recommendation to apply prone position is also supported by the recent surviving sepsis campaign guidelines. Obviously, this is a weak recommendation, and there is a low quality of evidence. So finally, what are the expected benefits of neuromuscular blocking agent in patients receiving mechanical ventilation? The most common indication for a neuromuscular blocking agent is to facilitate mechanical ventilation. And when appropriately used, it is quite clear that neuromuscular blocking agent will improve chest wall compliance, may reduce airway pressure, and may also prevent respiratory dyssynchrony. And also, we do not have probably enough time to more extensively discuss about that point. There is clearly accumulating evidence suggesting that respiratory dyssynchrony, especially reverse triggering, may be common during mechanical ventilation of ARDS patients, and even in those receiving deep sedation and during controlled mechanical ventilation. And I would encourage you to give a look to the results of a recent multicentre observational study, which was just accepted for publication in the Chest Journal, that suggests that reverse triggering may be found in almost 1/2 of mechanically ventilated patients with ARDS not receiving neuromuscular blocking agents after intubation. The surviving sepsis campaign guidelines again issued a weak recommendation to use continuous infusion of neuromuscular blocking agent in the event of ventilator dyssynchrony, as this is the fact in case of mechanical ventilation associated with high airway and high plateau pressure. The other point is that neuromuscular blocking agents may facilitate the use of recruitment maneuvers, and this is especially interesting when we want to avoid inspiratory effort, unwanted inspiratory effort or caus, which may lead to a huge and prompt increase in airway pressure and possible barotrauma during the maneuver. The other point is that the use of neuromuscular blocking agent may also help control ventilation in patients with high respiratory drive, which can be also the case in patients suffering from COVID-19. And also the use of and the early use of ventilatory modes allowing spontaneous breathing is usually recommended as soon as possible, at least in order to prevent diaphragmatic atrophy or to enhance weaning from mechanical ventilation. This should be clearly balanced with potential harmful effects. And a high respiratory drive is not a rare condition in patients with ARDS, and also in case of COVID-19, for which spontaneous breathing can lead to asynchrony with high tidal volume, even if a low tidal volume, a protective low tidal volume is set on the ventilator, but could also lead to uncontrolled transpulmonary pressure and possibly to patients' self-inflicted lung injury. And for example, in this elegant cohort study from our colleague from Toulon, including patients with COVID-19 and receiving spontaneous breathing using APRV and PSV modes, the author found that PO1 was frequently above 3.5 centimeters of water in patients with COVID-19 and even higher than 6 centimeters of water in a quarter of patients. So we have to give a look to PO1 and probably to airway driving pressure, to respiratory drive, in COVID-19 patients. There are obviously some expected adverse events with the use of neuromuscular blocking agent, and the use of NMDA has been linked to increased risk of ICU-acquired weakness. This concern is probably one of the deterrents of their use in most patients with ARDS. However, the most recent and largest trial to date, in my opinion, which used the validated medical research council score, found identical risk of ICU-acquired weakness at day 28 and at ICU discharge, whether the patients received or not neuromuscular blocking agent. However, even if the risk is low, it is, in my opinion, logical to consider that the shortest duration of use should be obviously considered in these patients. So, as a conclusion, what can be considered for clinical practice? There is probably no logical reason to promote systematic use of neuromuscular blocking agents for all mechanically ventilated patients, whether for COVID-19 patients or for patients suffering from other pathologies requiring invasive mechanical ventilation. However, in my opinion again, and we obviously can discuss about it, neuromuscular blocking agents should probably widely envisaged in moderate to severe COVID-19 associated ARDS, especially when prone positioning is indicated in case of excessive airway pressure, excessive plateau pressure, in case of asynchrony, and obviously also to avoid unwanted deep sedation. But in any case, the duration of infusion must be as short as possible in order to avoid possible side effects with the use of this medication. I thank you for your attention.